Each step of phaco surgery is critically important, and probably none more so than the incision. Any error with the incision can have significant consequences both during surgery and further down the line. Some well-known intraoperative problems include conjunctival ballooning if it's too posterior, wound burn if it's too tight, and peeling of Descemet's membrane. Postoperative problems can range from induced astigmatism if the incision is too central or too wide, to an increased risk of endophthalmitis if it's not watertight. This video has been produced to try and help you avoid these problems by giving you a better understanding of the principles of wound construction. This should help you to make incisions that are correctly structured and therefore sutureless, self-sealing, and astigmatically neutral. All incisions can be described in terms of two defining parameters: location and architecture. Of the two, architecture is the more important because it determines the integrity and stability of the wound. Location describes its two-dimensional position, both circumferential, usually superior or temporal, and radial, either clear corneal, limbal, or scleral. Architecture describes its three-dimensional structure. This includes its width and length, together with the internal contour, which is either a single plane, two-step, or three-step. So let's deal first with choosing the location of the incision. How do you decide where you're going to place it? It's here that size is important. The guiding principle is that wherever you place it, the incision causes some flattening of the cornea along that meridian. How much flattening is directly related to the width of the incision and inversely related to its distance from the center of the cornea. So, the width of a clear corneal incision can only go up to 3 mm plus or minus 10% without inducing astigmatism. If you need to make a larger 5 or 6 mm incision for any reason, then you'll need to move it 2 mm back onto the sclera if you want to keep it neutral. Connecting the ends of these two incision lines defines the astigmatically neutral incision funnel. Any incision placed within its boundaries is neutral. So first of all, think about how the incision width can affect the choice of its position relative to the limbus. Next, you have to decide on its circumferential location. Most surgeons are more comfortable operating from above to begin with, and move around to the side later on when they're more experienced. The temporal approach can give better access in difficult cases, and temporal clear corneal incisions may induce a little less astigmatism. You have to decide for yourself what works best for you. Above all, do what's safest in your hands. Wherever you do choose to sit, try and place the incision where it's comfortable for you to handle the instruments. This means that if you're right-handed and operating from above, then put the incision between 10 and 11 o'clock, and if you're left-handed, then put it between 1 and 2 o'clock. Try to avoid the 12 o'clock position, which, although aesthetically symmetrical, everybody finds uncomfortable. Now let's take a look at the architecture of the incision. The basic principle to emphasize here is that its architecture determines the stability of the incision and makes it self-sealing through the flap valve action of the tunnel floor. Remember the three components of the architecture: width, length, and the internal contour through the cornea. The width, of course, is the easiest of the three to control because in most cases it's predetermined by the width of the keratome. The length and internal contour are more of a challenge. They require careful alignment of the blade and accurate control of its passage through the cornea in order to achieve consistent results. So now let's look at how to control the length and contour of the incision. Firstly, the length. Ideally, it should be between 1.5 and 2 mm. This ensures that it's self-sealing and also allows good surgical access. The length is controlled by the angle at which the keratome penetrates the cornea. So if you go in too steep, the incision ends up too short and it leaks. On the other hand, if you go in too flat, then the incision ends up too long, which gives poor access, distortion, and wound burn. For corneal stab incisions, you should pass the keratome in the plane of the iris and slightly upwards to get an incision that's the right length. Secondly, and finally, let's look at the issue of the internal contour of the incision. This can be constructed either as a simple one-step or stab incision, a more stable two-step grooved or hinged incision, or a very robust 3-step profile used for wider incisions. All 3 profiles can be corneal or scleral, and if properly constructed, create stable and self-sealing incisions. Their detailed construction techniques are shown in other videos in this section. So, that really covers the basic principles of phaco wound construction. Remember to plan the width of your incision and to use the concept of the incision funnel to determine where to place it relative to the limbus. Decide whether you're going to operate from the temporal approach or from above, and then try to place the incision in a position that's comfortable for you when you're using the instruments. Think about how you control the length of the incision by adjusting the angle of the keratome. And for corneal stab incisions, you should keep it in the plane of the iris to get the right length. Also, be aware of the 3 different contours that you can use: 1-step, 2-step, or 3-step. When you're familiar with the detailed techniques of wound construction, you should practice them in the wet lab. You'll soon be able to consistently construct correctly contoured incisions that are sutureless, self-sealing, and astigmatically neutral.